I'm very excited. This is our third webinar that we've done, and we have some really great talks this year. And I'm really pleased that Chung Jenny has joined me to be the associate chair, and we're both chairs, co-chair of this working group because it's a really great working group, and I think we've done some really fun things in the past year or two. Go on, next one. So, thanks for joining. I just want to say a little bit about our special interest group. So we meet and we talk about patients who have had complications from childhood cancer or chemotherapy or other things. It's very informal. We meet on the third Thursday of the month between 4 to 5 on Eastern time. Anyone can join. So after this, if you have an urge or want to, just shoot us an email or let us know, and we will add you to the list. Um, I want to just mention at the ATS this year, we have two Meet the Experts, which is very exciting. Jenny and I are going to do one on how to diagnose BOS in pediatric stem cell patients. And I want to say that Shailendra and Sumani are going to do lung transplantation post-childhood cancer therapy. So those are two pretty exciting things. We also will meet as a group, tentatively scheduled on Sunday, 11:45 to 1:15. We will announce the place, and generally we meet to kind of discuss what we want to do this upcoming year, different ideas, and whatnot. And we will send out a agenda for that also in the next couple of weeks. Well, probably closer to the ATS. This session will be recorded, so if for some reason you have to hop off or your friend didn't get a chance to join it, there will be a recording. If you signed up for this, you get the recording, and if not, you can find it on the ATS webpage. And then next, cool. So I'm just going to introduce Jenny, so Jenny is a former CHOP-ite who's now at Riley Children's. She's taken over there by storm and has developed their post-cancer therapy and BMT and monitoring and all kinds of good stuff. And I'm going to let her do the rest.
Thanks, Sam, for the introduction. Hi, everybody. I am very excited to be here today for our annual webinar. Like Sam said, we've done some really, really fun things over the years. We've had some fantastic talks that's planned for today with experts from all over the country. So here is the panel of speakers. I am just going to give a brief overview of pulmonary complications of childhood cancer to start. As background, we have Dr. Andrew Limper from Mayo Clinic, who is going to be talking about drug-induced pneumonitis with traditional chemotherapy and targeted therapies. Then we'll have Dr. Ajay Sheshadri to continue with drug-induced pneumonitis part 2 with some of the more novel therapies with immune checkpoint inhibitors and also CAR T-cell therapy. Dr. Shailendra Das is going to be talking about pleural parenchymal fibroelastosis, or PPFE, which is a pretty hot topic within our community right now. And then finally, Dr. Daniel Gomez is going to finish up our day with radiation pneumonitis. Each of our moderator is going to introduce our speakers, and so we can learn more about them and their amazing accomplishments. But I wanted to take this time to welcome and to thank our moderators today. We have Dr. Wai Wong from Boston Children's, Dr. Brandy Johnson from University of Florida Health, Dr. Stephen Rose from University of Nebraska Medical Center, and Dr. Cissy Si from Stanford University. So thank you for all the speakers and moderators and everyone who's joined us today. Okay, so to kick things off, I am going to again give a brief overview for pulmonary complications of childhood cancer so that we have ample time for each of our speakers later. In the modern era of cancer therapy, the survival rates of childhood cancer have improved significantly over the years. So there are actually currently over 1 million pediatric cancer survivors in the United States currently. And if you really think about it, this is a pretty incredible number. It is estimated that 1 in every 640 young adults between the ages of 20 and 39 years old is a survivor of pediatric cancer. Unfortunately, this increased rate of survival does not come without a cost to the survivors. There is significant long-term morbidity and mortality that is associated with the treatment of childhood cancer. And specifically, pulmonary complications of childhood cancer is quite common, with sequelae that last many years after completion of therapy. And in one article that I found, the mortality amongst 5-year survivors of childhood cancer is 8 to 10 times higher than those of general population. So I think pictures are worth 1,000 words. On the right, you'll see this graph. This is data from the Childhood Cancer Survivor Study. And on the y-axis, you see survival function estimates. And on the x-axis, you have time since diagnosis. The yellow line represents the US population over time. And you can see the blue line represents cancer survivors. So you don't even need to see the fine numbers, but as you can see, the outcomes are significantly disparate between the two groups, with overall mortality increasingly significantly over time in the survivor group. And so I think, I'll just take a pause. This is why our group cares, right? Like, so many of us are here today, and within our interest group, we are here really to learn and to understand these complications so that we can continue to help our patients who have fought their cancer so heroically and actually survived to have a better life and a healthier life. So when thinking about pulmonary complications of childhood cancer, it can be divided into acute, early, and late effects. Acute effects are typically found during cancer treatment. Early effects can occur anywhere between days to weeks to months during and after treatment, and can include infections, pneumonitis, pulmonary edema, or just ARDS. Late effects of pulmonary complications can occur anywhere between months to years after treatment. And of note, cardiopulmonary complications are the third leading cause of mortality among survivors following cancer recurrence and secondary malignancies. The sources of lung injury can include chemotherapy, radiotherapy, surgery, and hematopoietic stem cell transplantation, and we'll hit on a lot of that today. Other factors to think about are recurrent infections, impaired growth, so that could be from cancer therapy itself or even just the underlying disease processes, chest wall abnormalities, and also other organ dysfunction may further influence long-term health outcomes. Typically, the pulmonary complications can present with pretty unspecific symptoms such as dyspnea, chronic cough, exertional limitations, and recurrent pneumonia. But sometimes individuals can also be just asymptomatic, but can present with abnormal PFTs or incidental radiographic findings, which highlights the importance of practicing always with a high index of suspicion when thinking about pulmonary complications, and also the importance of having screening protocol for those that are at risk of pulmonary complications to enable early detection and intervention. And for example, recently our group has contributed to the development of screening guidelines and surveillance for bronchiolitis obliterans syndrome after pediatric stem cell transplant. So in conclusion, as the survival rate of childhood cancer conditions continue to rise, it is our responsibility to closely monitor these individuals and to understand the mechanisms behind the complications and to identify risk factors for early detection and to ensure effective treatment. So with that, I'd like to welcome our first moderator and first speaker to start our session.
Limper, if you want to pull up your slides.
Sure.
I want to introduce Dr. Andrew Limper, who graduated cum laude from the University of Illinois at Urbana-Champaign, then earned his medical degree from the University of Illinois College of Medicine. He completed his training in internal medicine and pulmonary critical care at the Mayo Graduate School of Medicine, followed by a research fellowship at the Washington University. Dr. Limper was the former chair of the Division of Pulmonary and Critical Care Medicine and the Associate Dean of Practice Transformation at Mayo Clinic. Currently a professor at the Mayo Clinic, Dr. Limper is an expert in interstitial lung disease and with particular interest in drug-induced lung diseases and pulmonary fungal infections with over 300 published manuscripts. He also leads research on lung fibrosis and infections in immunocompromised patients. He has won numerous distinguished awards and mentored dozens of trainees and junior faculty in academic medicine. So I welcome Dr. Limper to start our webinar.
Well, thank you. I'm very excited about this. I'm planning to learn as much as I hope I can share with you. And I'm going to be covering traditional chemotherapies and some of the targeted therapies related to drug-induced pneumonitis. And let's see if I can get it to advance. Yeah, I don't really have any relevant disclosures. My cases that I'm showing are coming from the Pulmonary Critical Care Division at Mayo, as well as my own personal cases. I'm not really talking about anything that is off-label use for my disclosures. Now, the one disclosure I got to make is I'm not a pediatrician. The median age of my patients is 75. And in fact, these three little guys over there are my grandkids, two granddaughters and a grandson. And I get a cold sweat whenever I get the call on the weekend. They're 9 months, 4 years, and 7 years. And I really hate it when they get the little iPhone out and they're asking me to look at a skin rash. And all I can remember is viral exanthem. So that's what I spit out. That's the only thing I remember from pediatrics. So at any rate, you got to forgive me on that. But I think we're going to discuss the variety of drug-induced lung disease for conventional chemo and targeted therapy. And what I hope I can give you is an approach, a clinical approach to the differential, to backing into the diagnosis. I'm saying that intentionally because it's really not definitive, the diagnostics for drug-induced lung disease, and then some tips on managing these cases. It's a case-based discussion. Unfortunately, as I don't see kids, these are not kid-based cases. Some of them, as you'll see, have some roots in childhood as well, and those long-term survivors are very important as we continue to see people that got treated during their childhood for malignancies into adult life. So at the FDA, oh, now they don't report anything, right? But there are about 1.5 million adverse drug reactions related to the lungs are reported to the FDA annually, and most don't go reported. Most are unreported. It costs a lot of money, and the morbidity and mortality related to adverse drug reactions across the country has been estimated lung-related morbidity and mortality at $15.5 billion. I think that's probably 10% of the total because these things are massively underreported. I see a drug-induced disease related to an alkylating agent. I don't keep reporting it after I've seen it unless it's a brand new thing. I don't report it. There's over 500 reported drugs, so I'm not going to be able to go over all of that in 20 minutes, so don't worry about it. In fact, my little timer is not even going. Now it's going. Okay, so get out the hook if I go too long. But what I want to do is give you an approach to this. Now, this was a funnier slide about a month and a half ago when there weren't all these air things. I know all of us are getting edgy to get on, but I love this because, you're going to have to hang on tight. There's just lots and lots of stuff. So please see the forest overall of clinical approach for the trees of the individual. And I'll give you some resources that I hope you already know about, but to remind you about how to get there. Now, what medications are used that cause lung pneumonitis, lung toxicity? There's the classic antibiotic chemotherapies, bleomycin and mitomycin C. Really, any alkylator, cyclophosphamide, busulfan, nitrosoureas, oxaliplatinum, etc. Those are a target area. Antimetabolites like methotrexate certainly can do that. Gemcitabine, fludarabine, azathioprine rarely can cause toxicity, and 6-mercaptopurine. The tubulin agents, vinblastine, of course, is the classic. And then the podophyllitoxins and taxanes all can cause toxicity. Then we get into the more novel agents as listed, and tyrosine kinase inhibitors in general as a class can cause an interstitial pneumonitis. Gefitinib and imatinib have been best described. And we get into all of the targeted therapy, small molecule kinase inhibitors like gefitinib, erlotinib, lapatinib, BCR-ABL kinase, tyrosine kinase inhibitors, of course, dasatinib and imatinib, as I mentioned, ALK and BRAF inhibitors, and then targeting other things like VEGF, bevacizumab, etc. Monoclonals, particularly, rituximab gets used a lot in hematologic malignancies, and you need to be aware about what rituximab can do. Trastuzumab as well, and then analogs of rapamycin also can cause issues. And I put that down at about Fabian Maldonado and myself do the up-to-date on the targeted therapies. It's there. It's updated all the time. And so if you need a good resource, read that. I guess I also keep writing the Murray and Adele chapter on drug-induced lung disease, but the up-to-date on the most recent stuff is there, and then I'll give you the online resources. So one of the things we need to think about is the tempo of disease. Because we need to think about whether it's acute interstitial pneumonitis, more subacute like cryptogenic organizing pneumonia or eosinophil, or a granulomatous process could look sarcoid-like, or a hypersensitivity-like reaction, and then the more long-term chronic pneumonitis fibrosis patterns also. And so that helps me to realize that there's a whole spectrum of these pneumonitis. Now, I hate to admit it, close to 20 years ago, we had a small group get together at the ATS. We presented our findings, and we came up with these clinical criteria. One is that the symptom complex is consistent with the suspected drug. The time course, as I mentioned, acute, subacute, or chronic, or delayed, can also be compatible. It's reasonable. You have to back into the diagnosis. You have to exclude the competing diagnoses, particular infection or recurrence of disease in the lung, or volume overload, heart failure, etc. And you really get your best hint by objective improvement after you stop the drug, with or without steroids. Sometimes steroids help, sometimes they don't. I know there's always concerns in kids with giving corticosteroids. The bowel or the sampling, either the tissue or the bowel, will be compatible, but almost never in itself diagnostic. It's usually used to exclude the other stuff. Now, in the old literature, there was lots of talk about rechallenge. As a general rule of thumb, I don't rechallenge or don't recommend rechallenging. There are some exceptions. Low-grade toxicity with the immune checkpoints, you can get away with putting them back on if they had low-grade toxicity. Some of the other agents, some of the rapamycin analogs can certainly be rechallenged, and sometimes the patients do well at lower dose. But in general, I don't recommend rechallenging because there have been lots of cases of deaths from serious toxicities by rechallenge. Now, I'm going to have some cases. This is a 32-year-old male that had acute non-lymphoblastic leukemia treated with cyclophosphamide, methotrexate, and bleo. And then he had this massive spleen, so the spleen gets pulled out. And within a couple of days, a day or two after that splenectomy, he deteriorates, and he has fluffy infiltrates in all 5 lobes. And it's really what we all need to know about. But we all know about it as pulmonary-based folks, but we got to tell the anesthesia folks about it. We have to tell, we keep needing to do ongoing education, because this has been known, as I said, since 1978. It's been revisited again in 1999. But when patients get exposed to high flow oxygen during surgery, they have a high risk of bleomycin-induced acute lung injury that occurs. That can occur years after the bleomycin exposure. And we just need to tell 2 things to the anesthesia people. Number 1, keep the FiO2 as low as possible. Number 2, keep the volumes and the pressures low. It really becomes a problem when you're doing single lung ventilation for a biopsy or something like that, and they overblow the lung. We have had these cases come in from outside. We've also had them occur once or twice a year at the Mayo Clinic, where I'm proud to work, but this shouldn't happen. So we have to keep reminding our colleagues about this. Another case of an acute lung injury or an ARDS. This is a 46-year-old woman that had high-dose cytosine arabinoside for bone marrow transplant conditioning, and during her conditioning gets whited out lungs. You can barely see this on this old chest ray. Of course, it's ICU chest x-ray, so they're not that valuable anyway, other than to see where the lines are at and where the tube is at and such. But you can see fluffy infiltrates in the shadow. And when patients go to biopsy, which we routinely don't do, but you will find these rare patients that go to biopsy or unfortunately autopsy, and you'll see hyaline membrane. You'll see just a diffuse alveolar damage pattern, and those can occur with many drugs, and I'll review that. So in the case of RSC, it's rapidly onset within about a day. It has a high mortality. Patients are often misdiagnosed or undiagnosed. They're thought that they have some kind of an acute infection. They get antibiotics. They really don't do well with or without corticosteroids. Corticosteroids should be administered, although the data is light on that. Gefitinib, one of the targeted therapies, is an EGF receptor tyrosine kinase inhibitor. In adults, it's used in non-small cell lung carcinoma, but they have a pretty significant, like a 10% rate of developing an acute lung injury. Again, you see kind of these alveolar type, ground glass type of infiltrates. There's a really important point on the third bullet down. Any pre-existing lung disease, particular any interstitial infiltrates that you might see on your pre-treatment x-rays, and I really advise that you do get pre-treatment imaging as good as possible, because the patients that have stuff in their lungs beforehand have between a 5 and a 10-fold higher risk of drug-induced lung disease across the board with any agent. This can have a pretty high mortality, and again, gefitinib can cause a diffuse alveolar damage. So we reviewed just to see what happened in our practice. We did an epidemiology-based study, 8,000 patients. About 500 met the criteria for acute lung injury that we looked at. But as you see together between probable and possible, you actually get about 10% that are drug-associated acute lung injuries. Now, we have a busy oncology practice, of course, here, but you need to be aware of that when you're working the ICUs. And indeed, these are the listed drugs. I did this with Ogi Gaich, myself, and Dokar, one of our fellows, and we published this in Chest over a decade ago. But you could see really alkylating agents, busulfan, BCNU, cyclophosphamide, the various targeted therapies can do this too. Across the board, mitomycin, the antibiotics, and as I said, bleomycin does this in this setting, particularly of oxygen therapy as well. And we won't talk about the non-malignancy treatments on the other side. So this is not almost always a board question, but it's on the boards a lot. But, which drug, is associated with a granulomatous reaction? I don't have the audience response. Just keep a little thing in your brain, but I'm hoping that most of you guys are saying methotrexate, because methotrexate causes a granulomatous type reaction. This is another old related. See, my patients are not like your patients, but breast cancer getting cyclophosphamide, methotrexate, and 5-FU, and she gets this pleuritic chest pain, no cough, no hemoptysis, no fever. She has a little wheezy sound. She has a past history of PE, and then you look at the chest CT scan. I know I give you the answer that it was negative on rapid sequencing and contrast infusion for PE. But you look at these wedge infiltrates, and they certainly look like Hampton humps to this old guy here. And, so your first concern, a lady had a prior PE, is to really exclude PE. You have to do that first. Exclude infection. And that's a tougher thing with little kids than it is in my patients, because we just bronchobust all of them, or almost all of them. But we can get to that in a few minutes. I know kids, you have, at least when I visit with my pediatric pulmonary, they do the bronchoscopies, but they're not quite as trigger happy as we are. And so at any rate, in this case, this did go to get a needle, as you could probably see from the CT scan. I'm not backing up well. So the CT scan, the needle did show granulomas. There it is. The little arrow is by a multinucleated giant cells, a granulomatous type reaction. And this was with the methotrexate. Interestingly, the patient gets treated with steroids, and methotrexate is one of those unusual drugs you can give again, and sometimes they don't get the granulomatous reaction. In general, I try to avoid it in the granulomatous response. So methotrexate pneumonitis, dyspnea, non-productive cough, can have fever or not, can have peripheral eosinophil or not, They can have histopathology, a nonspecific pattern. They can have a UIP pattern, granulomatous pattern, as we talked about, organizing pneumonia pattern, or a diffuse alveolar damage. And it fell off the bottom of the list, but they can also have an eosinophilic pneumonitis pattern. So the same drug can manifest in many, many different ways. Now, this is a lady that had metastatic cancer and also got methotrexate, got the same regimen as the prior lady a few cases back, had a week of progressive dyspnea and cough, and you're looking at all these shadows and, lots and lots of infiltration. And as I said, you back into the diagnosis because she might have something different. And in this case, she got bronchoscopy, and we see pneumocystis jirovecii. Of course, I'm going to show that pneumocystis jirovecii sent my kids through college, and I've done a lot of work in pneumocystosis, but it can occur with steroids, but it can occur even with low dose and intermittent dose methotrexate. We've shown that it can occur with intermittent corticosteroid therapy, and of course, with all of the lymphocytic toxins that they get. So it is a real concern, and of course, you need to treat that differently. We tend to, the adult practice, to go to lavage because it has a real high sensitivity, which I've outlined here, particularly for the fungi, which I've been interested in, but also good for getting cytologies for malignant cells, getting hemacytoid macrophages for hemorrhage. Drug effects, sometimes you'll get eosinophils, sometimes you'll get lymphocytosis. Most time in the drug, you don't get either one of those. You get kind of a gamish with neutrophils, and it doesn't tell you anything, but it does tell you that there is not infection. Tobias Picourt reviewed our series here, and as I said, fungal pneumonias, particularly pneumocystis, have a high take rate on bronchoscopy. One thing that was really useful that you can kind of we only do BAL alone. We don't do BAL and TBLBX transbronch biopsies in adults at the same time in Mayo Clinic because the yield of that extra risk of the transbronch is relatively low. And I know in kids, you're doing tracheal aspirates and you're doing all these other non-invasive stuff to try to avoid doing bronchoscopy. But if you do bronchoscopy, I mean, certainly your lavage alone can be done with, I think, pediatric scopes have a single channel. Isn't that correct? I don't know. You can tell how long it's been since I've ever done bronchoscopy on a kid, like in training 35 years ago. Another entity, cyclophosphamide, another alkylator, this has, if you see this CT scan, all this pleural pulmonary fibrosis in this patient that was actually several years into receiving multiple courses of cyclophosphamide. And we've reviewed this. Saeed Malik and Ulrich Spex looked at that. And, we've had, very few patients, but we found two categories. We have an early reaction to cyclophosphamide that if you stop the cyclophosphamide and give steroids, they tend to get better. But this later pleural pulmonary stuff just does not get better, even if you stop giving them cyclophosphamide and even if you give them steroids. Well, organizing pneumonia is another subacute thing. 28-year-old male had Seminoma, treated with the old classic Einhorn with Bleo and etoposide and got VP16 and developed cough and nodular infiltrates. And, obviously, in somebody with Seminoma, the first thing that's popping into my mind when I saw this is, oh my gosh, this guy has recurrent Seminoma in his chest. Fortunately, where the arrows are showing, these are right near the chest wall, and we could do a CT-directed needle and get some material. And you can analyze, and sometimes in a needle, you'll see Masson bodies, you'll see organizing pneumonia and a sea of chronic inflammatory cells. And that's, in the old terminology, used to be called BOOP, but it's really organizing pneumonia. And you really can't call it cryptogenic organizing pneumonia because it's drug-induced organizing pneumonia. Now, this list is growing and growing. Bleo does it, amiodarone, sulfasalazine, radiation can do it, even outside the radiation port, mitomycin, cyclophosphamide, etc. But the list keeps growing. We've actually seen organizing pneumonia with things like rituximab as well. Okay, again, another case of more chronic. This 42-year-old woman had a non-Hodgkin's lymphoma, methotrexate, vincristine, hydroxydonorubicin, and Bleo, and over months had progressive cough and dyspnea. And I don't have the CT scan from this, but the CT scan really looked like somebody that had usual interstitial pneumonitis, idiopathic pulmonary fibrosis, lots of chronic dense fibrotic infiltrates, and mainly in the bases and coming in from the outside in. The way we see an IPF, I see a lot of IPF in my practice. And really, this is a chronic bleomycin. I'm just showing that the same drugs can have multiple reactions. And indeed, when they get biopsied, sometimes I've gone over these with Tom Colby a number of years back before Tom retired, and indeed they look all the world like you're dealing with usual interstitial pneumonitis and fibrosis, UIP type pattern. They don't do well with steroids. Those acute things with bleo, you give them steroids and things tend to go away. These chronic things don't really respond to steroids. As you all know, bleo and related agents have been used for lymphoma, heme malignancies. 10 to 20% of patients get pulmonary toxicity. Oxygen's a big risk factor, but so is radiation. Now, risk factors of the dose, that's an adult dose of getting 450 units over time. I guess, on smaller bodies, you would have lower dose. Screening and monitoring has been this huge area of debate. So, there's been these studies that shows that DLCO doesn't predict significant bleotoxicity. But I'll tell you what I do. I get imaging as they ask me what to do, but I would get imaging at the beginning of chemotherapy. At the minimum, a chest x-ray, if you could get a scan, and I know sometimes the little kids are going to have to, sedate them, anesthetize them to get the scan. Make sure that the lungs look good so you have something to go on. And then be able to monitor as best you can. And I know the pulmonary function testing within kids is also a challenge over time. But that monitoring, if you see a trend downward, it really, during chemotherapy, it is really an indication you got to reevaluate, and unless some other reason is causing it, stop. So, chronic fibrosis, there's a real problem with bleomycin. Delayed fibrosis also occurs. The classic is, get it in your mind, vincristine, hydroxydonorubicin, nitrosourea, methotrexate, cyclophosphamide, BCNU, carmustine, and nitrosourea is the answer. I have a bunch of these that I've had in my practice, like a bunch, 4, 5, that I followed over many years. There are people that had nitrosoureas in adolescence for CNS tumors and other malignancies, usually CNS tumors. And they have done well, but they end up with this upper lobe fibrotic pattern as well that can develop years later. And this kind of shows it. You can see the upper lobe infiltration of nitrosourea, delayed fibrosis. Okay, so I'm going to wind up because I'm almost done anyway. And of course, it occurs in about a third of the long-term survivors, so it's a big problem. And, the estimated incidence is relatively pretty high. Steroids are tried, but of really very limited benefit. Now, there's a whole long list of agents that cause chronic fibrosis that are listed, but really any of the alkylating agents, the antimetabolites can do this. Really, any variety of agents can cause this kind of chronic fibrotic drug-induced lung disease. And in the interest of time, I'm going to skip this rituximab case that ended up having, as you can see in the bases, some hazy infiltrates, because rituximab can cause infection, as we know, can really be a problem. In fact, I reported on the risk of fungi pneumocystis in rituximab, but it can cause all sorts of interstitial pneumonitis. And so we're going to wind up with 3 slides. This is a volume overload state for our brains. It's brain overload. So I want all of you, if you haven't done it, bookmark pneumatox.com. And it's down there at the bottom. Philippe Kemuva, I've collaborated with for years, maintains this. It's updated. If you have a drug that you're worried about, you can check it on pneumatox.com. And treatment for this is to withdraw the drugs, judiciously use corticosteroids, which are a concern in kids, and you need to support the patients when they're off the drugs with oxygenation. Sometimes they need ventilation, diuretics, and dilators. So I'm going to stop. And if I even have 2 minutes for a quick question, we could do it. Otherwise, we could take questions later.
So thank you so much for the talk. This was fantastic and very educational. We are running a little bit out of time, so we'll open up questions till later.
That's
as
fine
we
with
can
me.
go to the Next talk.
Thank you.
Thank you.
Oh, all right. Well, while he gets his slides going, I can go ahead and introduce Dr. Ajay Sheshadri. So Dr. Sheshadri completed his undergraduate degree at Rice University and then did his medical degree at the University of Texas Southwestern. He did residency in internal medicine at the University of Texas Southwestern and then went on to do fellowship in pulmonary and critical care medicine at Washington University in St. Louis, as well as completing a master's of clinical investigation as a postdoc research fellow in St. Louis. He is currently an associate professor at the University of Texas MD Anderson Cancer Center. Throughout his career, he's focused on advanced quantitative imaging in obstructive airway diseases, focusing particularly on bronchiolitis obliterans syndrome after stem cell transplant. And so they've done things like establishing a home spirometry program for stem cell transplant monitoring, using advanced imaging to characterize bronchiolitis obliterans syndrome, and evaluating epithelial cell biology and function for diagnostic biomarkers in this condition. He leads several studies examining clinical risk for pneumonitis and leads efforts to create radiomic and clinical prediction models for pneumonitis across a variety of treatments. And he's speaking to us today on pulmonary toxicities associated with immune checkpoint inhibitors and CAR T, which he's well set up to speak to. So I'm excited to hear him.
Thanks so much for the kind introduction. This talk will focus on immune checkpoint inhibitors and CAR T therapies. I tried to focus these specific drugs on things that are applicable to the pediatric population. These are my disclosures. None of them are relevant to the current presentation. So I want to start by talking about immune checkpoint inhibitors. These are a class of drugs that I think are gaining a lot of recognition for their ability to treat very refractory cancers. It's a very interesting story that's a little bit beyond the scope of the current talk, but the idea that T cells can have a role in cancer immunity was a little bit of an outsider idea, but starting in the 80s, work from Jim Allison, who's now at MD Anderson, started to show that T cell immunity plays a crucial role, particularly in murine models of melanoma. And what he found was that the CTLA-4 receptor, which is essentially a receptor that binds to stimulatory receptors on the T cell and downregulates them, by blocking this particular inhibitory pathway, you can activate T cells. And so this allows the T cell to sort of function uninhibited and potentially destroy tumor cells, although, as we'll see, it also can potentially target non-tumor cells as well, too. Simultaneously, a group in Japan also discovered another pretty crucial checkpoint, which is the PD-1 and PD-L1 axis. In this case, PD-1 on the T cell binds to PD-L1 on an antigen, and this binding actually results in T cell exhaustion. And the reason that this exists is to prevent autoimmunity. So this is sort of the body's natural way of sort of putting the brakes on the immune system. And again, by blocking this inhibitory pathway, we can actually activate T cells. So immune checkpoint inhibitors started out with a relatively small role in advanced cancers and metastatic cancers, and really only a handful of cancers. And I think this paper shows really nicely the expansion just in the last decade, where in 2011, only 1% of cancers had an indication for immune checkpoint inhibitors. But in 2023, over half of new cancer diagnoses had an indication for immune checkpoint inhibitors. And this runs the gamut from lung cancer, which is one of the more common ones, all the way to lymphomas and melanomas. Of course, many of these are more applicable to adults than children, but some of the general principles that we're going to talk about apply just as much to children. The problem with immune checkpoint inhibitors is that you get immune-related adverse events. And so this is a set of, basically, you can consider them to be autoimmune events. And they can affect just about every organ that you can think of. And so some of the common ones include colitis, dermatitis, pneumonitis, which we'll talk a little bit about. But some of the more serious ones, including pneumonitis, are also myocarditis, myositis. Sometimes you have overlaps of myositis and myocarditis with a myasthenia gravis component as well, too. We call that triple M syndrome, which is particularly fatal. So there's numerous off-target effects that occur because if you think about it, this is a relatively blunt way to activate the immune system. We're not really targeting a specific agent. We're just disinhibiting the immune system and allowing it to do its thing. So I'm going to focus a little bit on immune checkpoint inhibitor pneumonitis. This is the main lung toxicity associated with immune checkpoint inhibitors. The incidence in the early clinical trials is 1 to 5%, but we see rates as high as 10% in the real world. Now, I think this is a little more applicable to adults in the sense that the higher rates are often seen in folks who have some pre-existing lung disease. Dr. Limper alluded to this, and we'll talk a little about it further as well, too. If you have some prior lung damage, you may be more likely to get pneumonitis. And so the rates may be a little bit lower in children, although there's not as many cohorts in children as there are in adults. One of the key things is that the fatality rate is quite high. So if you look at the studies and look at grade 5 pneumonitis, which is a fatal case, we see anywhere from 8 to 15%. So you can use 10 to 12% as sort of a rough rule of thumb, meaning that these are patients you're trying to cure for cancer and they're dying within the first 3 or 4 months of this fatal lung injury. We've also shown in a few different studies that pneumonitis has significant impacts even if you survive the initial injury. So on the left, there's a group that showed that pneumonitis increases healthcare utilization, so ED visits, hospitalizations, critical care services. We showed that if you survive pneumonitis, you're more likely to develop new hypoxemia, new pulmonary symptoms, or persistent scarring. And then on top of this, there are several groups that have shown that pneumonitis increases mortality, but the increase in mortality is beyond the acute fatal injury. Part of the reason that you might have an increase in mortality is that once you develop an immune checkpoint inhibitor pneumonitis, you're no longer eligible to receive this therapy, particularly in severe cases. And so you go to next line therapies, which may not be as effective. And so there's a big need to understand who's at risk for pneumonitis and how we can mitigate this without eliminating the possibility of giving the drug. The biological drivers of immune checkpoint inhibitor pneumonitis are still being worked out. But I can summarize several studies that have looked at this using blood and also BAL samples. And what you see, especially in the lung, you start to see a type 1 skew in the T lymphocytes. And in particular, you see a shift away from naive T lymphocytes to effector and memory T lymphocytes. You see a relative depletion of T regulatory cells. One thing that we're finding more and more of is that you see this expansion of monocytes. But if you look at monocytes as a whole, you may not notice this. But if you look at subsets, you could see a significant shift away from an M0 or inactive or an M2, which is antifibrotic, anti-inflammatory, to an M1 skew. So these are pro-inflammatory monocytes that secrete molecules like IL-6 or IL-1 beta, which are well known to cause lung injury. And in general, you can see an increase in IL-1 beta, IL-6, TNF alpha, and to an extent, the IL-17 and IL-23 pathways. We also know that ILD and interstitial lung abnormalities increase the risk for pneumonitis, and this is an area that we're very interested in. Again, this is less applicable to kids because most of what you're seeing here is a function of aging plus a component of genetics. This is probably best described in Japanese cohorts where the rates of ILA and the rates of pneumonitis seem to be higher, but we've shown it in our cohorts here at our institution as well as in numerous other places. But whether you look at ILD, so these are the clinical syndromes like idiopathic pulmonary fibrosis or interstitial lung abnormalities. So these are basically abnormalities on the CT that don't necessarily fit a specific ILD pattern, but they might denote early ILD. You see a significant increase in the risk for pneumonitis. And in fact, when you break it down a little bit, you see that risk is highest in subpleural fibrotic ILAs. So this kind of points us to one of the main risk factors that we think is pertinent in adults is that you have early fibrosis of the lung and some predisposing damage. And for whatever reason, that predisposing damage makes it more likely that you're going to get pneumonitis. And exactly how that happens is something that's not fully worked out yet, but hopefully we'll be able to have some insights into it in the near future. I'm going to shift a little bit and just talk a little bit about how to recognize pneumonitis. And so Dr. Limper pointed out a lot of different radiological patterns that are seen in drug-induced pneumonitis. And an immune checkpoint inhibitor pneumonitis similar to those, there's not really one canonical pattern that you need to pay attention to. You have to have a low bar for diagnosing the disease. The most common pattern that you see is organizing pneumonia. Organizing pneumonia typically presents as peripheral multifocal consolidation. But organizing pneumonia itself is a somewhat heterogeneous entity and can present in a lot of different ways radiologically. Interstitial pneumonitis is the typical pattern in about a third of patients, and then you see a mixed pattern in about 15% of patients. In our experience, I would say that about half the patients have some features of more than one sporadic ILD, and so we see a lot of mixed patterns, and so we don't rely as much on these anchoring diagnoses as we did early on when we were first studying this disease. Here's some examples of what checkpoint inhibitor pneumonitis looks like. On the left, you have two baseline scans of people with lung cancer, and then in the middle, you see them as they develop checkpoint inhibitor pneumonitis. In both of these cases, you sort of see this somewhat typical pattern of peripheral consolidation in GGOs. And then after steroid therapy, even though there's clinical resolution, you can often see some degree of scar. You shouldn't treat the scar as if this were active pneumonitis unless the patient has active symptoms that are concerning for ongoing pneumonitis. I'm going to summarize the management of immune checkpoint inhibitor pneumonitis here. I'm going to focus on the clinical grading, which is based on the CTCAE criteria. There's a radiological grading as well too, but I think that's less established and not well validated with data. The clinical criteria are relatively straightforward. Grade 1 pneumonitis is asymptomatic pneumonitis. Grade 2 pneumonitis is we consider it to be anyone who doesn't require hypoxemia. It's defined as minor symptoms interfering with activities of daily life. Practically speaking, this can be a wide range from very minor symptoms that are barely noticeable to more significant interference with activities, but not requiring supplemental oxygen. Similarly, grade 3 has a relatively wide bucket where you can have a minimal requirement for hypoxemia with relatively minimal symptoms to pretty significant hypoxemia and on the verge of requiring more intensive care. Grade 4, typically I would put a high flow nasal cannula into this category. In addition, non-invasive ventilation and mechanical ventilation belong in this category. This is associated with a significant increase in the risk for death. And then grade 5, of course, is fatal pneumonitis. We'll talk a little bit about the management here. Grade 1 has relatively unique management because in these cases, you can hold the drug, but you don't need to give steroids. You can wait to reimage for the next cycle, and then you can decide at that point whether to give steroids or not. In grade 2 cases, you'll hold the drug, and it'll be held for a period of 2 to 3 months, depending on how long it takes the pneumonitis to resolve. In most of these cases, and perhaps even in grade 1 cases, we advocate for BAL for a lot of the reasons that Dr. Limper said, primarily to rule out infection. We don't have diagnostic biomarkers, although those are being studied. But if you can rule out infection, then you can treat more comfortably with steroids, with PJP prophylaxis. Ideally, you want symptoms to improve to grade 1, meaning that they're completely asymptomatic, regardless of what the imaging shows. You also want to see some improvement in the imaging before considering rechallenge. And then we work closely with the oncologist to decide when to rechallenge. And it's a little bit different from patient to patient. Grade 3 is similar to grade 2, but these patients are usually in the hospital. Sometimes you can consider a higher dose of steroids. Sometimes you might consider IV methylprednisolone instead of prednisone. These patients are often monitored closely for at least 2 or 3 days in the hospital, and if they start to improve, they can be discharged on supplemental oxygen. If they don't improve, you need to consider second-line therapies, and we'll talk about what those are. In grade 4 cases, generally speaking, we use 2 milligrams per kilogram per day until there's significant improvement, and then we think about weaning to oral prednisone. We usually start second-line therapies relatively early in the course just because there's a high risk for fatality. These patients are often in the ICU or in some sort of step-down unit where they can be watched more closely. I want to talk a little bit about steroid refractory pneumonitis. So we're going to focus on this top right here. This is from an ASCO guideline focusing on steroid unresponsive IRE. So these are, in the case of pneumonitis, these are patients who are not improving with their oxygenation. They're still requiring substantial support despite corticosteroids. There's also steroid-resistant IREs where they're just not improving fast enough, and you can consider second-line treatments in these cases as well too. There's really not great data for guidance here. At our institution, we use infliximab 5 milligrams per kilogram for 1 dose, and sometimes we'll use a second dose. Some institutions will use more than 2 doses, but there's not a whole lot of guidance on exactly what the optimal strategy is. Other options include tocilizumab, which is an anti-IL-6 agent, mycophenolate mofetil, or IVIG. This is an area that is in dire need of study. So I'm going to stop there, and I'll take any questions at the end. And I wanted to kind of switch to the second part of the talk, which is CAR T therapies. So CAR T therapies are, more and more commonly used in children and adults, primarily for B-cell malignancies. And these are really remarkable sort of living therapies that have emerged and continue to grow at a very rapid scale. We're seeing more and more of these used in adults for solid tumors. None of those have received an FDA indication yet, but that could rapidly change within a period of months. The idea behind CAR T cells is that you essentially have a T cell that targets a specific antigen. In this case, it may be something like CD19 or BCMA, which is expressed by the tumor surfaces, but might also be expressed by some healthy cells. In addition, you have co-stimulatory domains that are in these engineered T cells, and they allow the T cell to be permanently active, and they allow the T cell to expand quickly when it recognizes a target. So that's part of the reason that these are considered to be living therapies. This is the current set of indications for CAR T therapies. So you have 4 CD19 CAR T therapies and 2 BCMA CAR T therapies that are primarily for multiple myeloma. So less of a concern in kids, but in kids, you're going to see this used in non-Hodgkin's lymphomas and ALLs that are expressing these B-cell antigens. Now, with CAR Ts, we're going to take a slightly different approach because the main risk is more related to the immune deficiencies than the acute cytokine response. And so we'll talk a little bit about the immune deficiencies that occur after CAR T, and then we'll talk about cytokine release syndrome, which is the primary manifestation of non-infectious acute lung injury. So understanding how these immune deficiencies occur and when they resolve will help you understand the relative risk for infection versus cytokine release syndrome. So when you give a CAR T therapy, there's a period of lymphodepletion that occurs before the CAR T infusions. So during that period of lymphodepletion, you're going to have significant lymphopenia, significant neutropenia. The IgG levels are relatively normal, so you don't get hypogammaglobulinemia early. That's a later phenomenon. But you do see these significant cytopenias, and those start to resolve by about 1 month. With ANC, you start to see resolution by about 1 month in about half of cases, and same for ALC as well too. B cells take a little bit longer to recover, and they may not recover because of the mechanism of action of these drugs. And then the same with hypogammaglobulinemia. This tends to be something that nadirs around 1 to 2 months, but it may not recover quickly because of the mechanism of action of these drugs. So if you look at the type of infections that people get with these drugs, early on within the first 100 days, you see a lot of bacterial infections. You see some pneumonias that are not clear in terms of the origin. You see some fungal events and some viral events. Now, as time goes on and you're looking at the late period of CAR T between day 100 and 1 year, you see a lot of respiratory events. You see more pneumonias, more bacterial infections, more viral infections. As the cytopenias improve, you see fewer fungal infections. So this gives you an idea of the type of viruses that you see. So for example, early on, there's a relatively broad differential, including things like pulmonary aspergillosis. But later on, you see a lot more respiratory viral infections and more routine infections. So where does cytokine release syndrome fit into this picture? So cytokine release syndrome can look a lot like sepsis or pneumonia. And this occurs as the CAR T products are expanding in the body. The symptoms include fever, chills, myalgia, fatigue, shock symptoms, as well as capillary leak. And this usually happens in the first 2 weeks. So this is pretty important to understand because beyond the first 2 weeks, it's more likely to be an infection. But in the first 2 weeks, you have to consider cytokine release syndrome. And severe cytokine release syndrome occurs in 5 to 7% of patients. Again, this is kind of a picture of when cytokine release syndrome occurs. Typically occurs in the first couple of weeks, particularly between week 1 and week 2. ICANS, which is a neurological consequence of CAR T, can occur with a slightly broader window. And then this is just the general guidelines for how to treat cytokine release syndrome. So the grading is, again, primarily clinical. If you don't have any significant hypotension or hypoxemia, these patients are just observed. In cases that are a little more severe, if you have some hypotension or hypoxia, you should treat supportively. You might think about giving medicines like tocilizumab to reduce symptoms, but these patients can often just be observed as well. And with supportive care, they'll get better within a few days. In grade 3 cases, these patients should be considered they should be followed in the ICU. You should consider giving additional therapy, for example, with tocilizumab. And these patients should be monitored very closely for any further decline. And for grade 4 cases, these patients should almost universally be in the ICU. This is when you start seeing life-threatening CRS. And these patients can get very sick very quickly, and the recovery can be quite prolonged as well, too. So I'll just summarize here, just because I think we're running out of time. Distinguishing CRS from sepsis is important. CRS is a clinical diagnosis. There are a lot of studies that have looked at specific cytokines and markers. None of those are validated. So at this point, you need to have a high suspicion for CRS early on. And I think, once again, early bronchoscopy is helpful to rule out infections. And I'll go ahead and stop there. And if we have time for questions, we can take a couple questions.
Thank you. That was really great. Do we have time for, I think we have about 5 minutes for questions. One question I'd had was, you mentioned like with the CAR T therapy, in the first early weeks, distinguishing sepsis from cytokine release syndrome. Are there longer term pulmonary effects of the CAR T therapy?
No, generally not. And this is something that we also were curious about as these therapies were first coming out. And in particular, we were thinking about CAR T a little bit like hematopoietic cell transplant. So, do you get any long-term effects like airflow obstruction or pulmonary fibrosis or anything like that? Generally speaking, no. Cytokine release syndrome tends to be self-limiting. Of course, with severe lung injury, you might see some post-arch fibrosis, but most people do really well. And so once you're out of that first initial burst of inflammation as the CAR T product is expanding, then most of what happens after the first month is usually infectious related. So that makes it easier for us as pulmonologists to think about, what are we looking for? If you're beyond that initial period, then almost always it's going to be some kind of infection. And then the types of infections, of course, as the cytopenias start to get better too, the types of infections become more like typical respiratory infections. In that early period, that's where you have to be a little more judicious and probably pretty aggressive with your diagnostic workup.
Well, thank you. Other questions from any of the audience?
Jay, so sounds like if there's not long-term pulmonary complications that we know of, would you recommend any surveillance protocol for CAR T, or do we not know, or are there guidelines around it?
I think it's a great question. There's no guidelines around it. I mean, generally speaking, we don't do any long-term pulmonary surveillance like we do with hematopoietic cell transplant. So right now, there's no good evidence to support a long-term surveillance, since there's really not any long-term complications, not from a pulmonary function standpoint. A related question, which I think is that one is a little more provocative, is whether we should do any pre-CAR T pulmonary function testing to select patients. So there's 2 studies. One of them is ours, and one of them is a group from, I believe, from Israel that were just published this month. The group from Israel, they didn't see any association of pulmonary function tests with toxicity, but they found an association with survival. We found the opposite. We found association with toxicity risk, but no association with survival. Both are pretty small studies, and so I think you're likely to come to different conclusions. So I think the jury's still out on that. I'd like to see that study get done systematically because I think it's an important study. But right now, there's no guideline recommendation to do any kind of pre or post pulmonary function testing for CAR T recipients.
Thank you.
There's a
I see.
question, yeah,
Yes.
from Dr. Tilley. Hey, my name is Dr. Tilly. I'm a pulmonologist from Montreal. The question I have is, I have this interesting case who is a now 12-year-old who got CAR T in 2019, who had hypogammaglobulinemia, was treated very quickly with IVIG, still on IVIG to this day, and came to me, I would say in 2023, with diffuse bronchiectasis. And unfortunately, it made sense to me considering the side effects of CAR T, but I could not find a ton of information when we were looking at the literature. And the only way we found it was with her symptoms, because she was not being followed by PFTs, and her symptoms were at least ongoing for 2 years. FEV1, I want to say, was in the 50s when I met her, and with standard non-CF bronchiectasis treatment, she went back to an FEV1 of 100. So I think this probably speaks to perhaps the need for close follow-up.
Yeah, I think specifically with bronchiectasis, that's that's one of the areas where long term with the low IgG levels, you're going to see some risk for that. I think it's a good point. I would say the analogous population that we have in adults is CLL, for example, and those patients have low IgG levels, they have poor humoral immunity, and they develop bronchiectasis over time. Many of them, we don't monitor them with pulmonary function tests. I think you could argue that. You could also argue just monitoring their IgG levels and their respiratory symptoms. I think these are things that'll get worked out as we get more experience with them. But I think that's a good point, that bronchiectasis is potentially a late pulmonary complication of CAR T because of that effect.
Well, thank you so much, Dr. Sheshadri. I think we'll turn it over to the next speaker.
So today I have the pleasure of introducing Dr. Shailendra Das as our next speaker. Dr. Das is a pediatric pulmonologist and associate professor in the Department of Pediatrics at Baylor College of Medicine and Texas Children's Hospital. He's worked at TCH for the past 10 years, and during much of that time, he worked as a member of one of the largest lung transplant programs in the country, where he became familiar with the disease entity for which he's about to present to us today, pleuroparenchymal fibroelastosis. In addition to lung transplant, Dr. Das serves as the primary ciliary dyskinesia center director and as the bronchoscopy director. He's an active member of the ATS and has been a part of the special interest group for the past 8 years. I want to welcome you and thank you for speaking today, Dr. Das.
Thanks, Brandy, for the introduction, and thanks for the organizers for inviting me to speak today. As Brandy mentioned, I became interested in this disease entity after having several patients come through our transplant center. So I'll quickly get started. I do have a lot of slides to present, and we'll try to get through as many as I can. I did serve as a BI advisory committee member for those years I listed. These are my objectives for this talk. So I'll focus, this is not meant to be a primer on PPFE. I want to focus more on the therapeutics and kind of the emerging literature that's come about. I did give a talk in a similar forum last year on PPFE that was recorded. It was an hour-long talk. I'm happy to share the link in the chat at the end of this talk. And as Sam, Dr. Goldfarb mentioned, Dr. Srinivasan and myself will be doing a post-childhood cancer therapy leading to lung transplantation, meet the experts at ATS. I'll start with a case presentation. So this is a now 15-year-old male with a history of neuroblastoma stage 4, diagnosed at the age of 4. He received an autologous bone marrow transplant at the age of 5, and then subsequently received abdominal radiation therapy. 3 years after the autologous bone marrow transplant, he presented with chronic cough, and his FEV1 at that time was 68%. He continued to function in decline, eventually couldn't climb the stairs without feeling winded, short of breath, and the PFTs were consistent with a restricted pattern. Unfortunately, he was lost to follow-up for a couple of years, and this is the pattern we see, honestly, commonly on our referrals to transplant, actually. So 6 years after his initial pulmonary visit, he developed chest pain and was found to have a pneumothorax, which remained persistent. Because of the persistent pneumothorax, he underwent blebectomy and had a pleural stripping biopsy done at that time. He continued to clinically decline and eventually was referred to our center. At the time he was referred to our lung transplant center, he had an FEV1 of 16%. He eventually did get transplanted and actually did quite well after transplant for a while. So this just helps to introduce the topic of PPFE. So PPFE is defined by the ATS and ERS as a rare condition that consists of fibrosis involving the pleura and subpleural lung parenchyma, predominantly in the upper lobes. CT shows subpleural dense consolidation with traction bronchiectasis, distortion of the architecture with upper lobe volume loss. And you'll see some of the clinical findings that go along with this upper lobe volume loss. The fibrosis includes elastic deposition of the subpleural regions, and you see intra-alveolar fibrosis. Unfortunately, the incidence is not well understood. Mainly, it's because it's an underrecognized and underdiagnosed entity. And in pediatrics, from what I understand exclusively, we see it as a secondary disease only. Now, in the adult world, about 50% of PPFE ends up being idiopathic in nature. And I mentioned that it's often thought to be POS. A lot of the referrals we'll get say a child has bronchiolitis obliterans syndrome when actuality they have restrictive lung disease that's associated with PPFE. It is an entity seen in post-lung transplant. So if you do lung transplant for a living, this is chronic rejection in the form of restrictive allograft syndrome, which we see in incidence of about 7 to 30%. And the pathologic correlate for RAS is PPFE. And in adult literature, they say post-BMT, we see about a 0.3% incidence. There is some pediatric literature that I'll go over regarding post-BMT PPFE as well. Early on, the clinical symptoms are very nonspecific. Some non-productive cough, mild weight loss, exercise fatigue, and exertional dyspnea. Now, it's important to note that the patterns that are seen in PPFE, they can have a very slow and slowly progressive onset or a very rapid onset. And this actually bimodal distribution is actually described in an ATS Annals paper reviewing PPFE back in 2019. Some patients have no symptoms for a long time, but then we are seeing mild lung function changes consistent with a restricted pattern and some pleural thickening on imaging. And pneumothorax actually may be the first true presenting sign. Patients that tend to have evidence of air trapping, so high RVA to TLC ratio, and patients that have been on steroids are higher risk for having pneumothoraces. There are some unique clinical features, and unfortunately, some of these are more later in the progress of the disease, but they are differentiating disease features that are important to note. First, really bad chronic malnutrition and a low body mass index, which is representative of progressive worsening of metabolic demand. Platythorax, and this is one of the more common features we see in our patients, so a decreased AP diameter along with a pectus excavatum kind of deformity develops as a result of upper lobe volume contraction and that decreased chest wall bulk. And it can lead to one of the more pathognomonic findings, this deepened suprasternal notch, which I'll show you a picture of in a second. On exam, you can have normal auscultatory findings. Some patients tend to have crackles on exam, but the majority of our patients actually have had normal findings. That chronic malnutrition is important to note. The worse, obviously, BMI, the worse the outcome. This study published about a year ago looked at 71 patients with idiopathic PPFE and showed that the survival is less in those patients that presented underweight in the adult cohort that they present. Also showed that the patients that continued to have progressive weight loss also showed a worse outcome versus those that were either normal weight or basically normal weight. This is that deepened suprasternal notch that I was talking about earlier. And actually, there was one paper that described the prognostication of having a deepened sternal notch versus a superficial or not having a deep suprasternal notch. And those patients that have this deepened suprasternal notch tended to have worse outcomes, which may relate to just a representation of how bad the fibrosis is and how the upper lobe volume loss is. This is a common finding I see in my patients, and I actually look for it now when patients get referred to. Briefly talking about the imaging pathology, just to run through it. I'll just focus on the definite criteria. So the definite CT findings that we see, you tend to see upper lobe pleural thickening and subpleural fibrosis, and key component is lower lobe volume is not usually involved. And that from the adult world tends to differentiate it between idiopathic pulmonary fibrosis versus idiopathic PPFE. And so they talk about this definite criteria of not having lower lobe involvement. There's obviously murky pictures, but talk about the consistent width, and I'll go over that in a second as well. Histological criteria, PPFE, you tend to have more upper zone fibrosis of the visceral pleura with that elastic deposition and alveolar septal elastosis and fibrosis. And you tend to have more in the peripheral regions, not in the more central regions. So you have sparing of the parenchyma distant from the pleura. And then this, at most, small numbers of fibroblastic foci. Again, this is a component of what we see in IPF, idiopathic pulmonary fibrosis, that they want to distinguish and say it's not usually present in PPFE. We published a paper looking at radiographic findings, and the main findings that you see is platythorax with a reduced AP to transverse diameter ratio. You see this pectus of bottom as well. You also tend to see this overlapping of the trachea, basically approximation close to the vertebra, and then definitely see pleural thickening and reticular opacities as well. Again, not going too much over the histology, just want to kind of show you that you see this parenchymal sparing more centrally and out towards the periphery. You see this fibrotic tissue, and there's a deposition of elastin as well. There's one paper that looked at sensitivity, specificity, and accuracy if you looked at physiologic criteria. So showing a BMI less than 20 in adults, which corresponds to a Z-score of less than -1, evidence of air trapping, so an RV to TLC greater than 115%, and an AP to transverse diameter less than 0.58, showed a specificity in the upper 80s for when you had combined findings. It's important to note that you can have a mixed picture. PPFE can be seen in patients also with BO as well. And so where the biopsy, and we're not recommending biopsy, but if a biopsy was done, where it was done is important to kind of note. As an example, we had a patient with combined PPFE and BO post cancer therapy. And so for his BO, we would do pulse steroids to try to see if we could slow the progression. Unfortunately, his disease continued to progress, and he passed away while waiting for transplant. There are important disease associations, and that's what's kind of the secondary PPFE that we see in pediatrics. And there are multiple disease associations that we see. I mentioned as a form of lung transplant, so restrictive allograft syndrome, and then post hematopoietic stem cell transplant as well. I'll talk about that a little bit more in a second. We do see it in some patients with toxins or hypersensitivity pneumonitis, infection. So patients, there have been multiple case reports presented on patients with aspergillosis and non-tuberculous mycobacteria that have PPFE. Interestingly enough, when they're treated with antimicrobials, the progression of disease slows, and sometimes the CT change is reversed, actually. We see it also in a familial history. Now, we've had one patient that was actually already in our center who had 3 siblings that passed away, and all ended up having, when we look back at their biopsies, or autopsies, excuse me, ended up having PPFE. And so I watched the 4th sibling right now. Shortened telomere lengths, this is well reported in the literature. So we do sometimes get telomere measurements, and then we also do genetic testing for TERT and TERC mutations. The remainder of obviously why we're here today to talk about cytotoxic chemotherapy, and specifically alkylating agents. And Dr. Limper mentioned that earlier, that they can be associated with upper lobe fibrosis. I think some of the papers even earlier on than PPFE was recognized may actually relate to actually these patients having this kind of pleural parenchymal findings. And what we tend to see is alkylating agents such as cyclophosphamide, busulfan tend to be involved. And so there are a couple of papers published on in case series on pediatric cancer therapy, and then eventually developed PPFE. And so this one published last year looked at 4 of their patients. One had neuroblastoma, and 2 with soft tissue tumors, and then leukemias as well. But you look at the chemotherapy involved, and you see alkylating agents, basically specifically cyclophosphamide associated with all 4 of those patients. We tend to, in our institution, see these high-risk protocols for neuroblastoma actually being as a causative agent, with high-dose cyclophosphamide being one of the agents used in those high-risk protocols. What's also interesting to note, I think, in this paper is if you look at the age of diagnosis of the cancer versus their age of diagnosis of pulmonary symptoms, you can see a wide range before patients develop symptoms. This is a paper we published back in 2019. 8 of our patients that went on to lung transplant with PPFE. As you can see, as I mentioned, neuroblastoma tended to be the diagnosis we saw more. We also saw this in leukemia and soft tissue tumors as well. We listed the chemotherapy, and again, alkylating agents are associated. Now, there are some high-risk neuroblastoma protocols. I didn't put this in the slide deck only because it's more anecdotal than evidence-based, that I tend to tell our oncology teams that if these patients are on it, if you see any type of lung function changes or any type of new symptoms, to refer them to us so we can follow them long-term. I think key points of this is, like I said, alkylating agents appear to be associated. High-risk neuroblastoma, soft tissue protocols seem to be associated based on the fact that these patients are on these alkylating agents as well. And again, there could be a huge time lag between the initiation of chemotherapy and the onset of these clinical respiratory symptoms. Now talking about post-BMT and briefly touching on lung transplant. So post-BMT, there is actually one paper published that took 738 patients from their institution that underwent hematopoietic stem cell transplant and looked at the incidence over time of ppFE and found an incidence of 4%. And I'll talk about that in a second. And those patients had a mixed picture of both cancer pathology, or excuse me, both cancer pathology leading to BMT, and then also a mixed picture when it came to ppFE and other diagnoses. When we look at post-lung transplant, as I mentioned, clinically, we see we diagnose them with this restrictive allograft syndrome. And the incidence is somewhere around between 7 and 30%. What we need to know is it's associated with really poor outcomes. And like I said, people that do lung transplant and see this restricted pattern know this. The survival, so if we look at a median survival of about 6 years in lung transplant, the median survival in these patients with RAS tend to be around 2 to 3 years or less with once they get diagnosed with RAS. And so this is the paper I was talking about with post-BMT. And so we look at the survival curve to start with in patients that underwent bone marrow transplant and then developed ppFE. There were 738 patients in the total cohort, 31 of which had ppFE. And at the time of the paper, 73% of those patients had passed away. And the median survival was about 6.8 years. And so it's important to note that development of ppFE post-BMT exists, but also that it can be associated with worse outcomes, and to follow these patients closer and consider the therapies I'll talk about in a second. Interestingly, the only thing they found in multivariate analysis that was associated with worse with development of ppFE was having a pneumonia 3 months after, or 3 months or more after hematopoietic stem cell transplant. Kind of mentions two things. I think these are patients obviously to watch once to follow more closely for onset of restrictive disease, but also that we probably don't know enough, that we need to know more of what other risk factors truly involved in development versus not developing ppFE. And so now I'm just going to focus mainly going forward on the review of treatment options that we have. There's not a lot treatment-wise. It's a really tough disease to try to maintain, to manage, and figure out what the best treatments are. I'll focus on these last four, but just to kind of quickly mention, this actually is out of that ATS Annals paper from 2019. When you look at low-dose oral steroids, really unproven. A lot of our patients do come to us on some kind of steroid therapy for a long time, either oral low-dose or pulse steroids. In one study, low-dose steroids were demonstrated to show a benefit in changes in CT, but not with PFT results, and they continue to decline. The recommendation from the review paper in ATS Annals was that pulse steroids, other immunosuppressive agents, are usually avoided due to a heightened risk of infection. There's not a lot of data out there in isolation of using steroids now. There is emerging data with steroid use along with antifibrotic agents, but again, in small case series and studies. Antimicrobials, I mentioned already, when it comes to patients with aspergillosis or NTM infection, you may see some benefit to treatment and reversal. And lastly, the four things, so antifibrotics, pulmonary rehab, oxygen, and lung transplant. We know these two drugs, pirfenidone and nintedanib, to be the main antifibrotic drugs we think about right now, the two that are clinically available on the market. And we have used them in pediatrics now. Nintedanib obviously has been in clinical trials in pediatrics, but we've used both drugs off-label, and it's worth mentioning it's off-label. And I've used pirfenidone, and there's actually some literature that was published out of North Carolina that looked at their protocol for dosing pirfenidone and titrating up the dose and their experience using. There's two more recent studies that were published looking at ppFE and nintedanib specifically. And this first paper looked at 21 patients that had ppFE, 9 of which were treated with nintedanib and sometimes in conjunction with steroids. 6 treated either with steroids and immunosuppressive agents or pirfenidone, and then 6 that were untreated. And it actually did show some promising data in the sense that the decline in FVC over time did decrease once nintedanib was started. and that was statistically significant, and then did not change in the other cohorts. But again, in a small series of patients, there's possibly some benefit, and we see that graphically represented. You see the decline in lung function here. That's slightly better maintained once on nintedanib. Unfortunately, a more recent paper published looked at idiopathic PPFE and idiopathic pulmonary fibrosis, and looked at before treatment and during treatment again, looking at the annual decline in FVC, and of course did show benefit in IPF with a decline decreasing, which we know nintedanib and pirfenidone are both approved for IPF and show benefit in multiple studies for IPF. But in idiopathic PPFE, unfortunately, we see actually a worsening after treatment, probably related to more progression of disease versus actually the drug, but did not show benefit with trying to slow progression of disease. What has been shown in a couple of studies is that pulmonary rehab can be importantly beneficial to these patients from a quality of life standpoint, but also an exercise tolerance and a durability standpoint, I guess. This small study looked at 9 patients that underwent pulmonary rehab programs once they were diagnosed with PPFE, and showed actually a betterment of their 6-minute walk test after doing a pulmonary rehab program. Graphically represented. So 7 of the 9 patients actually had better walk distances after their pulmonary rehab program, and overall showed benefit. And that's actually one of the things I've anecdotally seen in my patients, and we're starting to write that up with our physical therapists to look at. So I'll talk a little faster. We have put our patients on high flow nasal cannula therapies, both in the inpatient and outpatient setting. So we use our Airvo and IOV setups. We haven't unfortunately seen benefit. We see continual progression of the disease. There's only one case report that I saw published on high flow nasal cannula therapy did show benefit for the patient from a quality of life standpoint, from a decrease in PCO2s, from a weight management standpoint, and from a breathlessness score standpoint. We'll see, I think time will tell if this continues to be beneficial or not over time. Non-invasive setups are slightly more concerning, only because of the risk of pneumothorax. Quickly talking about lung transplant, and again, we're doing a talk at ATS about this. Unfortunately, patients that are post-transplant tend to have worse outcomes than all-comers transplant. That was seen in our cohort, which we're working on our manuscript right now, and also in a paper published last year in a French study. We looked at 31 patients that underwent lung transplant. The median survival is the 5-year median survival is 38% versus 60% if you look at ENOS data for all transplants. What's important to note is the variables associated with early mortality. And so when we look at lung function, lung volume reduction, so these patients have these shortened AP diameters, and so to try to get lungs to fit based on what their height is, it's probably a mismatch. And so surgeons have to do lobectomies or segmentectomies, and that's associated with worse outcomes. These patients tend not to recover their FVC all the way to where we expect, probably because of that chest wall restriction. Patients also develop AKI often, and that's associated with early mortality. And they're chronically malnourished, and we see lower albumin levels, and that's been associated with early mortality. Similarly, we presented our data at abstract form 4 years ago at ISHLT, and showed a median survival of about 3.5 to 4 years versus our total cohort, which is 6 to 6.5 years. These are the main challenges that we face in lung transplant. Unfortunately, because the disease is underrecognized, we tend to get these referrals really late, and it's really challenging. We try to advocate for transplant, but we're on a ticking time bomb almost when it comes to having late referrals. Chronic malnutrition and trying to work on their nutrition status is very important. Size mismatching, which I mentioned already. These lungs are really difficult to get out, and so we tend to see extensive bleeding during surgery. I mentioned the AKI. The psychosocial aspect is worth mentioning real quickly. I tend to see 2 sets of patients, or at least early on. The first set was the set that kind of felt why this is happening again. They already went through a big hump when it came to their cancer care, and to have to deal with the second thing. So they tend to not believe in the diagnosis early on. And that second cohort of patients is Well, we've already been through one thing. We did fine, so we're going to do fine again. And so it's sometimes that kind of getting on board from the patient side is a little slow in processing too. I'll finish with my current approach myself. So I always discuss transplant with these patients, and I always discuss these patients with our transplant teams early on. I always discuss ECMO candidacy. The transplant teams always discuss ECMO candidacy. And we try to involve palliative care early on when we get. If the FVC is less than 30%, if there's significant functional decline or a history of pneumothorax, I tend to refer to transplant. I sometimes will see them first just to talk and kind of talk about transplant since I did it for 7 years as well. In the patients that are above those kind of markers, I do start a trial of antifibrotics. If they're tolerated, I continue them. I monitor PFTs, BMI, and 6-minute walk test. I enroll every patient in pulmonary rehab and work on nutritional status. If they can't tolerate PO, we do enteral feeds. Unfortunately, we can't do G-tube a lot of times because of the surgical risk, so we'll do it in G-tube. If hypercapnia is seen, we either do a high-flow nasal cannula or non-invasive, and we avoid biopsy at all cost. This algorithm is similar to what I just said for my personal approach. It's just it was published last year. For the oncologist on the call, referring early. So patients that demonstrate dry cough, subtle changes in lung function, specifically air trapping or mild restrictive disease, upper lobe changes, pleural thickening on CT, and if they have decreased AP diameter, platythorax or deep external notch, especially those that have been under high-risk protocols or post-BMT. Now, we don't know really if referring early makes a difference. It's difficult to tell at this standpoint. Lastly, where do we go from here? Definitely more education is needed, specifically reaching out to your long-term survivor programs, partnering with them on the pulmonary side, post-BMT programs, radiologists, and pulmonologists. We're starting to recognize this a little bit more. Management of pneumothorax and chest wall disease, we don't really have the best idea. I mentioned a lot of supportive management, but we don't know what's best right now. The timeliness of initiation of therapy, so antifibrotic agents or referral to lung transplant. And then lastly, there are a few of us in the room that have talked, Dr. Srinivas and myself, Dr. Cheng, and others have talked about a PPFE pediatric registry, which I'm hopefully get off the ground soon. This will help us with the epidemiology, what works and what doesn't, sharing of ideas as well, and what therapies that we've tried on our patients. I'll stop right there.
Thank you so much for speaking on such an important topic. If anybody in the audience has questions for Dr. Das, you can put them in the chat. And I think that some of our panelists are going to circle back around at the end to field some of those. For now, I'll go ahead and hand it over to Cissy for our next speaker.
All right, great. I have the pleasure of introducing Dr. Daniel Gomez as the last speaker today. Dr. Gomez, please feel free to pull up your slides. So Dr. Gomez attended college at the University of Virginia, traveled across the country for medical school at UCSF, and back again for residency in radiation oncology at Memorial Sloan Kettering Cancer Center. He was faculty at MD Anderson before returning to Memorial Sloan Kettering in 2019, where he currently serves as the director of the Thoracic Radiation Oncology Service and vice chair of clinical operations. Dr. Gomez is an active researcher with over 250 peer-reviewed publications focusing on lung cancer and the role of radiation in metastatic malignancies. So go ahead and take it away.
All right. Thank you so much for having me here. I'm honored to be presenting, and I'm really interested because it's not the typical audience that we have for the radiation pneumonitis talk, but I think that so I think it could be a very stimulating discussion with questions. So thank you for inviting me. So I'm going to just go over really what we know in the adult setting, and then we could talk about some data that was recently published at the end in the in the pediatric setting as well. But we'll start with adult and then move from there. So key points, particularly we know a lot of this from lung cancer, but it's because it's a very common malignancy. But but from this we can extrapolate with respect to what the hallmarks of radiation pneumonitis are, what the effects of various systemic therapies are, how we predict it, and how we treat it. So that's what I'll speak to today. So what is radiation pneumonitis? So I told patients that we define it in basically with about 3 or 4 criteria. The first is what are the patient's symptoms? So it's typically a pneumonia type syndrome. with some cough, shortness of breath, maybe a little bit of a fever. When does it develop? So that is really typically in the 1 to 6 month period, and we'll talk about acute versus late radiation pneumonitis and the difference between that. And then, does the patient have an inflammatory process that corresponds to the radiation field? And these can all be nuanced and a little bit complicated in an individual patient, but those are the 3 general ways we define it. So, we'll get the patient periodically where the physician will come in and they'll say, my doctor, has said I have radiation pneumonitis. And I'll say, oh, but you received, you just got your first 2 days of radiation therapy, so that doesn't really fit the criteria. Or my doctor says I have radiation pneumonitis. Say, oh, well, we treated you to the abdomen, so probably not radiation pneumonitis. So we still have these misperceptions, but in general, that's those are the criteria. So, so this is an example of radiation pneumonitis. So, and I think you can see why this is tricky. So you can see, this is relatively straightforward, treated here. You can see inflammation here in a patient that has symptoms. But it gets a little more difficult when you have the high dose area here, lower dose here, because you can develop an inflammatory reaction even relatively distant from the lung. So you can see, like, if you just looked at this, you'd say, well, this isn't due to radiation. The high dose is only here. Oops. But really, you have to look at the low dose area as well. Same with here, where they're developing the inflammation here. And then here as well, where you could see it outside of the high dose field, but still within the low dose field. There are several scoring systems. The main one that we use is the CTCAE version 5, but they're all very similar. Basically, grade 1 is asymptomatic with inflammation, and most patients will develop that. It's really not clinically significant. There have actually been studies showing that patients who develop grade 1 can have more control of their disease, probably because they're developing some level of an immune reaction. But grade 2 is when you start to get some symptoms. Grade 3 is more severe symptoms, and then grade 4 is life-threatening, essentially. We define the acute radiation pneumonitis typically is up to 6 months. Late is after that. Now, one could debate whether that's even could be classified as radiation pneumonitis versus just fibrosis, post-radiation fibrosis, and it is more difficult to treat the further you go out, because you go from this inflammatory reaction that we'll see we treat with steroids to a more fibrotic reaction, which is more difficult to manage. There are several mechanisms. I think in general, when a patient gets radiation, it causes the release of energy that then generates these free radicals. And these free radicals then can damage, DNA. That's how it kills tumors. But it can also kill lung tissue in that way. So this radiation-induced lung damage results from the combination of both direct cytotoxicity upon normal lung tissue, as well as then the development of fibrosis that's triggered by radiation-induced cellular signal transduction. So then basically it leads to loss of cell division, apoptosis, and then development of inflammation and fibrosis, which is then mediated by this cytokine activity and internal immune responses. They've seen that several pro-inflammatory cytokines are elevated in this process: TGF-beta, interleukin 1 alpha, TNF alpha. Now, what we do with this, I think, is still up in the air, but at least we're gaining a better understanding of what the etiology of these symptoms are. There are several predisposing factors. I think the 2 biggest ones are just dose factors. So what dose is the lung getting? And both the high dose and the low dose. High dose seems like is more meaningful than low dose based on our experience in lung cancer. And then what other treatment is a patient giving that may predispose them to this? We'll talk about this a little bit in a bit. Targeted therapy, immunotherapy, all of that can play a role in developing radiation pneumonitis. I know, some of these, the role of these in pediatric patients continues to emerge, but certainly having systemic agents on top of radiation can increase the risk and also complicate the picture. If the patient gets radiation therapy and systemic therapy and has infiltrates inside and outside of the field, is that because of radiation? Is this from systemic therapy? And then how do we manage that? Radiation pneumonitis also has some relevance in the setting of nuclear catastrophes, as you know, and this is where we glean some of our data. It's the pathophysiology is essentially the same as those treated with therapeutic radiation, and even in patients that are treated with a sublethal dose of radiation. And so this is the case in the atomic bomb in Nagasaki and this Chernobyl disaster. But so these same paradigms do spill over into those domains as well. So we've seen this in lung cancer, and I think in other cancers in general, that immune checkpoint inhibitors do increase the risk of radiation pneumonitis. And these are probabilities that we've seen recapitulated, but by adding things like immunotherapy, we have demonstrated an increased risk. And we've seen that this has two implications. One is that patients that get pneumonitis have symptoms directly on their quality of life. And then two, by getting a radiation pneumonitis, this often leads to discontinuation of what is effectively a good treatment, otherwise good treatment, and that can reduce their survival and increase the chance of progression. So we've seen both in the context of lung cancer and other malignancies, and we're seeing this here in lung cancer. So direct effect of getting radiation pneumonitis, and this secondary effect of leading to less effective systemic therapy regimens, and this holds across the field. People always ask, well, patients that get immunotherapy, do we hold radiation? And I typically say no for most of them. And certainly in lung cancer, I think this holds over to other cancers as well, that it really, for most patients, we're able to continue them. Pembrolizumab, durvalumab, agents like that. We'll often continue single agent IO, but we'll discuss with medical oncology, and we'll look at the size and the scope of our radiation field. And similar to the targeted therapies that patients get, both in lung cancer and others malignancies, we are seeing for some of these that there is a creep of radiation pneumonitis. This is for a lung cancer drug, osimertinib, but any type of TKI, I think that we typically err on the side of caution. Often we don't hold it, but we do individualize the therapy. Patients getting a high dose that are a high dose of radiation where it's meaningfully that it's reasonable that the patient hold for a few days before, during, and a few days after. We do err on the side of caution there. And this reason is because when we've looked at various targeted agents, we've seen that there is a risk, an increased risk in many of these with radiation therapy. This is again for a lung cancer drug, but similar paradigms hold for other targeted therapies. So, our overall guide, we get patients all the time with various cancers that we're treating with radiation therapy in the setting of metastatic disease. And they say, oh, can you radiate this lung cancer? I don't personally treat a lot of pediatric patients, but these same paradigms hold. Our general guideline is to continue for small fields. It's unclear because, it's unclear what benefit holding for short periods of time even has on radiation pneumonitis. I mean, this is a toxicity that typically manifests 3 months after treatment. So, does it matter if we hold for 3 days before, during, and 3 days after? I don't think we really know. And we just don't know what these interactions are. And again, they always have to be weighed against the risk of a patient going off an effective agent for a long period of time. So how does this play over to pulmonary cancer or to pediatric cancers? And there have been, has been some recent data on this, or recent consensus guidelines on this. where they've looked at clinical scenarios at risk for radiation pneumonitis in pediatric cancer, Hodgkin's lymphoma, non-Hodgkin's lymphoma, whole lung radiation, and partial lung radiation, as well as even craniospinal radiation, which you don't necessarily appreciate, but we do see some dose creep into the lungs there. And this is from Pentec, which is similar to our Quantec reviews in adult cancer. But you can see that they include a number a number of studies here, but ultimately about 11 studies were included in their modeling. And I think, which is somewhat reassuring, is that our models for adult cancer, which have been very carefully honed with lung cancer and other malignancies, have carried over to what the risks are in pediatric malignancies. So you could see similar dosimetric constraints, mean lung dose, V20, V10, the dose of lung receiving 20 gray and 10 gray tend to still hold in terms of what the risks are in terms of developing this toxicity. And then when we start to get over, a V10 of 40, a V20 of a median dose of greater than 10 to 12 gray, and a V20, particularly above, 20-30%, that we do see those incidences increase. This is typically this is very much a multidisciplinary managed malignancy. The pulmonologist, the medical oncologist, and radiation oncologist are all integrally involved in this approach. So the question we first ask, is this radiation pneumonitis? Again, it can be difficult to differentiate from other causes like systemic therapy induced pneumonitis. Does it extend outside the high dose radiation field? If it's primarily contained, we deem this typically radiation pneumonitis. There are rare cases where radiation pneumonitis can cause extensive reactions outside the radiation field, things like recall radiation pneumonitis. Those are quite rare. Our classic picture is the low and high dose radiation fields extend within the radiation field. And when does it occur? When we don't know, a lot of times we'll empirically treat, because the treatment is often the same, whether it's systemic therapy or radiation related, and we treat with a course of steroids. And then what is the optimal management? This is a good table that I found that details this is in a Delphi consensus study, where a Delphi consensus is where just multiple rounds of questions are posed to experts and they come up with recommendations. This had 31 experts in this study, in this round, and really this general thought of 1 to 2 milligrams per kilograms per day, PO or IV, and then tapering down is the approach that we take. So for a pediatric patient, lower. For adult, it's usually around 60 milligrams for a full-grown adult, 40 to 60 milligrams. So we typically default to this 1 milligram per kilogram daily, and then we taper down. Now, this is always an ongoing discussion. So, patients come in, they start to have some improvement. We check in with them week 1, week 2, should we continue to taper? If all goes well, we use 1 milligram per kilogram for about 2 weeks. Then we taper down about 10 milligrams per day over the next couple of weeks, 5 to 10 milligrams, depending on if it's pediatric or adult. And we all typically own the management of this. If we caused it, we'll own it. We're very experienced at this, and we'll only involve the pulmonologist as needed. So who do we typically refer to pulmonology? Patients with atypical symptoms, patients with severe symptoms, patients who can't receive steroids, or patients with significant symptoms after a standard course of steroids. And that's our standard management. Now, there have been other attempts to try to mitigate this, either in terms of treatment or prevention. This is our study looking at nintedanib. So nintedanib is used for idiopathic pulmonary fibrosis, and that shares a lot of the same pathophysiologic pathways with the subacute phase of radiation pneumonitis. This is a study that we did at our institution, actually closed early, unfortunately, but it was a double-blinded placebo-controlled trial where patients were randomized to one of the two arms. So they got either nintedanib plus a standard 8-week prednisone taper and nintedanib alone. The primary endpoint was freedom from pulmonary exacerbations at year 1. Ultimately only enrolled 34 patients for 30 evaluable patients, but we did find that the freedom from exacerbation at 1 year was 72% in arm A with nintedanib and 40% with arm B. The only, the primary downside is this combination did lead to more side effect by adding this drug than in the placebo arm. But this did show promise, at least in the prevention of some significant pulmonary exacerbations compared to placebo alone. So I think that there's promise there to develop agents like this going forward. We just need to accrue, and it can be difficult to accrue to these types of studies. And then at ESMO, there was a study that was recently published in terms of adding beclomethasone inhalers actually for the prevention of radiation pneumonitis. These are appealing because they're not a pill, and they use for high-risk patients with respect to prevention of radiation pneumonitis. These are patients that had stage 3A or 3B disease with lung cancer. So those are typically the ones that get the highest dose. And they either got inhaled beclomethasone prevention with concurrent chemoradiation or concurrent chemoradiation alone. You can see they reduced the incidence of radiation pneumonitis through the inhalation of beclomethasone, and it didn't seem to affect the overall survival. So this is an approach that we've it's not standard, but I think it's compelling. We still will give this selectively in our patients, reduce the incidence by from 36% to 53%, and didn't compromise the efficacy of this treatment. So we have a lot of discussions that we pose to the multidisciplinary team. The thoughts on, do they typically do Bactrim or PPI prophylaxis? We often do. There are other alternative strategies that can exist for the management of this toxicity. And when should we be referring patient to pulmonology? And there are other objective parameters that we can establish. Finally, the incidence of radiation pneumonitis is growing in the context of new immunotherapies and other systemic therapies. It's a substantial toxicity, and I think that it's something that, as an oncologic community, we should continue to prioritize. It can not only improve quality of life, but even overall disease outcomes and survival by mitigating the benefit of otherwise effective systemic therapy. And treatment options still remain limited. I mean, I honestly think like the NIH should put out an RFA specifically for this, because radiation is being used more in the setting of metastatic disease. It's a significant toxicity, both directly and indirectly. And I think that the therapies are limited. So it has that mixture of clinical need, lack of therapies, and clinical impact that I think new approaches are desperately needed. So thank you very much for allowing me to talk, and I'm happy to take any questions.
Good afternoon. Hi, I'm Donna Lee. I'm a pediatric pulmonologist at Hackensack. I was wondering your experience on radiation-induced fibrosis, which is not the acute phase, and there's always a risk of having fibrosis, and then the literature has said that can occur even 5 or 10, like beyond 5 years. Like, have you seen them, and then what's the lapse from the acute?
Yeah, I mean, fibrosis develops in many of our patients we treat with radiation. So, I would say a substantial percentage of our patients will have fibrotic changes. So the question is always, what's the clinical manifestation of that fibrosis? So I think paradigm A that we try to adhere to is that as soon as a patient has symptoms, we should immediately address very aggressively, because what we don't want to prevent is inflammation becoming fibrosis. So the earlier we can intervene, so a patient comes in 1 to 2 months, say, I'm sort of bad, but I'm seeing significant inflammation. I very quickly, move to treating with a high dose of steroids because we want to hit that window. Once it hits that window of fibrosis, if we hold off, it becomes much more difficult to manage. The therapies are limited. The chance of reversing pulmonary symptoms becomes substantially lower. And so really, our primary management strategy is avoiding that situation. So I think that's where we stand with them. Many patients will ultimately develop fibrotic changes after radiation. Many times they will be limited in terms of how symptomatic they are. But when they are symptomatic and they progress from an inflammatory stage to a fibrotic stage, that the management of that becomes much more challenging and there are limited treatment options.
Thank you.
In that vein, is there ever any utility in treating someone who's relatively asymptomatic but with significant CT findings? I had a patient who had metastatic neuroblastoma, had really profound CT changes, but she was fine. And by the time I bronched her, her entire right upper lobe had completely scarred down. So I had wondered whether steroids would have been beneficial in the earlier phase before it got to
I
that point.
think so. If a patient, every once in a while usually when a patient, I'll say this. So usually when a patient has symptoms, maybe I don't want to make that much of a generalization. It's rare for a patient, it's more rare for a patient to have symptoms and have very limited inflammation if it's because of radiation. So if they have symptoms, it's high likelihood that they will have accompanying inflammation that speaks to that. Now it's not uncommon for a patient to come back with significant inflammation and have more limited symptoms. And I'll get surprised sometimes. I'll see the scan, I'll go into the office, the patient room, and before I go in, I'm like, oh no, this patient must be quite debilitated. I'll come in and be like, yeah, I feel fine. So this is my thinking on this has evolved in my career. I initially would just hold off, say, great, we can avoid steroids. Let's not, steroids aren't pleasant, so let's forego them and see how things go. I've now, realized that many of these patients will ultimately develop symptoms, and then we miss a window where we can intervene. And so I will, if a patient is reporting any symptoms at all, or even if they aren't, I'll often offer them steroids if I'm convinced it's radiation pneumonitis. And only if they're very resistant to this and understand that we are in a window that that may close, will I forego steroids in that scenario.
Do you have any experience with ACE inhibitors? I've seen articles on that, like as a prevention, but
that's a great question. And there have been papers on that. They're certainly not routine in terms of, I think their role has yet to be established. I don't really use them, but I do think it's a compelling, it's compelling in terms of both prophylaxis and treatment. And I think it's one of these, it's a very common agent, something that could be tested relatively easily. I would love to see more work on that. Honestly, it's all wide open in this space. All we have is steroids. Still, we just have steroids. And there's other agents out there that are used to treat, analogous clinical scenarios. But, as we saw with our nintedanib study, it's so tough to enroll on them. And I'm not sure exactly why. I guess for that nintedanib study, I think we would have this picture where patients would come in, they'd have, sort of mild symptoms. They wouldn't want to put them on something else. They'd be hesitant to, put them on something else. By the time they get to, grade 2, often it's sort of realized too late maybe, and then they miss that window. But it should be, it should, my perspective is to be very aggressive, when, with symptoms and inflammatory changes. Late onset may not be symptomatic except for hypoxemia with
6-minute walk.
6-minute walk. The young kids also have lung growth to the chest wall that may also complicate. Should we monitor these kids differently? That's a very nuanced question. I think, all I can say is, my perspective on this is that the later you intervene, the more difficult it is to appreciate a change in symptoms. So I am confident in that assessment. Whether, what the nuances are of, whether that's, balancing that with the other considerations of a pediatric patient in general, I think are a little bit beyond my expertise. But I do think I am confident in saying that the longer you wait, the more difficult it is to appreciate an improvement.
Okay, this is also a perfect segue into my next question, and I don't know if everybody in the audience can help me. I had probably a 2-year-old with I think nephroblastoma, had radiation, had acute radiation pneumonitis at age 2, successfully treated with systemic steroid, and I put him on inhaled beclomethasone QVAR because of the small particle size, and there was 1 or 2 articles that said that perhaps it can help. So he did 3 months of QVAR or inhaled beclomethasone, did really well. Weaned off medicine because at the time he was only 2. We sort of follow, make sure that he's developing normally. Besides some cognitive developmental delay, he otherwise did okay. Lo and behold, he comes in, he's old enough to do lung function, only capable of doing spirometry. And the spirometry initially showed that he had an FEC, FEV1 around, the high 60%. So a little restrictive and not 100% sure. We can't confirm it with lung volume. And subsequently have been seeing him every 6 months, doing really well, doing everything he wants to do in school. And now fast forward, where last year when he just turned 10, that FVC and FEV1 now becomes mid-50s. When I look at him, he's growing taller. The chest wall looks okay. The CT scan looks no different. And the actually rates are the same. So now it's like he's not growing. So, but he's doing well. So but there's nothing on the CAT scan for me to go after to say, oh, this is where I see the problem.
Yeah.
And then my question is, what do I do with this? A kid who's otherwise functional, but seems like he's not growing, has now a obvious restrictive defect. And unfortunately, he still can't do lung volumes, understand the technique. So I can't even confirm, is it just really restrictive or is it, normal lung, but air trapping, therefore the functional portion is low. And he did 6-minute walk. He's okay. And he's going to school, doing things he wants to. He's a little overweight, but he's not obese. It's like his BMI is on the higher end, but it's just not over. So I can't even say that it is the obesity that's making his lungs restricted. So I'm at loss what to do. I don't want to put him through a more invasive procedure for somebody who's doing okay. On the other hand, every time I test him over the last, he's dropped a little bit. And so it looks like he's not growing because the actual volume that I can measure is normal. He's getting taller, so his percentage is getting smaller. So this will be like the perfect forum to ask. Anybody have suggestions? Should I just follow him? But at what point would I panic? Right. He went from the high 60 percentile to now at one point was low 60 and then went back a little bit and now it's in the mid 50s. But doing everything he wants to do. And I don't know if he's just used to living with limitation, right? Kids are amazing at adapting.
Adapting.
Right. So ideas?
I don't know. Anybody have a idea for this?
I mean,
I don't
yeah,
know.
I
Is
mean,
there
I hate to,
any chest wall abnormalities that's contributing to the inability for the lungs to get bigger, like a
no, not that
significant
I could.
pectus?
No pectus, carinatum or exvatum, and his chest wall size, as far as I can see, as he's growing taller, is going with him. And on the X-ray, there is no changes that we can see. It's like a bell-shaped chest or anything. Lungs look, when you look at volume and look at the actual parenchyma, looks fine. He has some old changes associated with all the previous stuff. It hasn't changed in the last 4 years or however many years that we're following him. So that's where I'm at loss. I have a functionally what looked okay, but a number that's starting to drop, and it's real. So I repeat every time he's low. I have him repeated like 4 weeks later to make sure it's not just because of technique or a recent illness. But now I'm seeing a trend to really now going down to the 50. So I can't even say it's within the variability, but nothing on for me to go after. I'm actually pretty aggressive when it comes to biopsy. I need to have a place for me to biopsy. And it's not even a place that I can say, oh, it's obviously abnormal for me to go after.
So, Donna, I think I'm sorry, I missed the first part of your question or concern, but in the past we published papers on looking at growth abnormalities in this cohort, and we looked at crown to coccyx height compared to their standing height. And some of these kids who received radiation therapy, some of them who received retinoic acid also had abnormalities in their growth plates. So they would have disproportionately, if they make the assumption that our head to coccyx and is a 1-to-1 relation, like between, from coccyx to the ground and then to your head. Some of these kids would have an abnormality in their upper body ratio it wasn't 1-to-1, it was like 0.8-to-1. So then they would, we just felt that in time, so what we did is we took their crown to coccyx measurement and doubled it. And so say they were 150 centimeters standing height, these kids turned out to be more closer to like 132. And then we put their values in and reran the PFT normative data, and many of them it increased. And we'd see probably like a 10 to 15, sometimes even 20% difference. And what I think it taught us was that these lungs were definitely undersized, but functionally they were they weren't as bad as what we thought. And their values, if it was like an FEV1 of 50, would go up to 65, for example.
Okay, so that's a thought. So maybe what I should do is actually look at the crown to coccyx and use that as a
So
way
what you do is just see if there's a difference between the crown to coccyx if you double that versus the standing height altogether.
Okay. And if there is a difference,
Then
I would just
I
double.
take that value. So say it's 132, I'm just making it up. And then I just plug that in and run the PFTs over again and see what they look like. And for the most part, it improves a lot of the functions. The one thing that gets a little goofy is DLCO corrected for volume, which I never quite understood because I think there's a height factor in it. But if you ignore that part, it usually works pretty well.
Okay, all right. So I'll give that a try. If not, I'll look you up and we'll have an offline discussion on this.
Sure.
All right. Thank you, Sam. Thank you.
You're welcome.
Thank you. Thank you, Daniel. Thank you.
Yes, thank you.
So Jenny, do you want to wrap up? I think we had a great session.
Yeah. Thanks everybody, all the speakers and moderators. I don't know if there's any questions. It is 4:07. Were there any questions in the chat that people still wanted to ask? Otherwise, I apologize. I actually had slides of both Sam and my email address. You guys can reach out to either of us and then we can get you guys answers from this session.
Or me, yeah, you can always reach out to me directly too.
Okay, yes. I might. Oh, go ahead.
Sorry, yeah, I had a question for Dr. Doss. With increasing awareness of PPFE, are you aware of any BMT or onco groups that are making any kind of changes or alterations to their treatment protocols for kids that have diagnoses that are implicated or exposure to regimens that are implicated in it?
Not that I know of now. We did a talk a couple years ago to our local group, and we asked how we could be involved. I haven't seen anything come about from that as of right now, but I'll circle back with them. But it's a great question. I think now it's more the awareness of if these patients were on this protocol to try to evaluate and send them to the pulmonologist.
Thanks.
Well, thank you, everybody. We've covered a lot of topics today, and I personally learned a lot and have a lot to think about. So I have put the slide up here now with both Sam and my email address. If anybody has any questions or would like to join our group, feel free to email us. But thank you guys again for all the speakers and moderators for another very successful webinar. We appreciate it.
Thank you for putting this together. This is great.
Great.
So
Thanks,
much.
everyone.
Same agenda.
Take care. Bye.